Bismillah ar-Rahman ar-Rahim. I am Dr. Zeinab Awad El-Sayed, Professor of Pediatrics, and I will talk to you today about the causes of arthritis. This lecture is intended to let you know the common causes of arthritis in the pediatric age group and the specific clinical features of each of these causes. You will also know the important laboratory investigations that will help you differentiate among the different causes. What is arthritis? Of course, as the name implies, arthritis is inflammation of one or more joints, and it can be easily diagnosed when you see a swelling in the joint. This swelling can be more obvious if you compare it to the other side, the same joint on the other side. This swelling might be just soft tissue swelling, or there might be an infusion inside the joint. If this is not present, then you have to have two out of the following three, which is limitation of the range of motion of the joint, tenderness over the joint or pain elicited on moving it, and the presence of heat over the joint, with or without redness. Two out of these three is enough for making a diagnosis of arthritis. There are three big groups of causes of arthritis. First is rheumatic diseases, and these include many examples. Infections as a cause of arthritis, reactive arthritis and transient arthritis, and these are called infection-related arthritis. In the face-to-face session, in each of these causes, we should recognize the age and whether the arthritis is acute, subacute, or chronic, as we said. I will start by rheumatic fever because, as you know, rheumatic fever is common in Egypt. The arthritis in rheumatic fever is polyarthritis, takes more than one joint. It migrates from one joint to the other. The joint is red and it leaves no deformity in the joint. In other words, it is a non-erosive arthritis. The rapid response to salicylates is considered a therapeutic test. The full diagnosis of rheumatic fever will be discussed in the face-to-face session. The first big group of arthritis are rheumatic diseases, and arthritis is part and parcel of rheumatic diseases in children, whether these diseases are organ-specific such as autoimmune hepatitis or systemic as in systemic lupus erythematosus. Juvenile idiopathic arthritis is one of the common rheumatic diseases of childhood, and it's diagnosed, it starts before the age of 16 years, because we know that if it starts after that age, then it will be the adult type rheumatoid arthritis. The diagnosis of arthritis rests on the criteria that I have mentioned a few slides ago, and the duration in juvenile idiopathic arthritis is 6 weeks or more. This indicates that this is a chronic arthritis. You have to exclude other forms of arthritis in order to say that this is an idiopathic arthritis. I quoted this table to you from the textbook of pediatric rheumatology, and it indicates the criteria that I have just mentioned. But in addition, I want to show you here the types of juvenile idiopathic arthritis. These types are defined by the picture of the disease in the first 6 months. If the number of affected joints is equal to 5 joints or more, then this is polyarticular juvenile idiopathic arthritis. If the arthritis affects up to 4 joints, then this is the oligoarticular or the polyarticular type. And if the onset of the disease occurs with the characteristic fever, which is a quotidian fever, in other words, fever that daily rises to 39 degrees centigrade and then comes back to normal. This is called systemic onset juvenile arthritis, juvenile idiopathic arthritis. The other types of juvenile idiopathic arthritis that are included in the classification are psoriatic arthritis, which is arthritis occurring in psoriasis. This is a skin disease that you will learn about, and as well as other forms of arthritis. Other features that help make the diagnosis of juvenile idiopathic arthritis is the presence of morning stiffness. In the morning, the child cannot move the joint and there is gelling in the joint. This is because of the edema in the tissues of the joint. Deformity in the joint helps you in diagnosis because this is an erosive arthritis. The arthritis causes also periarticular swelling, that is edema of the surrounding tissues. Non-specific tests like high ESR, positive C-reactive protein, all these are supportive for the diagnosis, and the presence of leukocytosis also. The presence of a positive rheumatoid factor can help make the diagnosis, but does not exclude juvenile idiopathic arthritis if it is negative, because it's positive only in a minority of the patients. These are photographs of some of our patients with juvenile idiopathic arthritis. In the upper right corner of the slide, you can see swelling of both hands over the carpal bones, and in the left hand you can see also swelling of the wrist joint. Both hands show flexion deformity of the fingers. This can also be seen in the picture on the left. In the picture below, you can see swelling of both knee joints, and you can notice the presence of a rash that is pale pink in color, what we call salmon pink rash, which is characteristic of systemic onset juvenile idiopathic arthritis. These are X-ray pictures of patients with long-standing juvenile idiopathic arthritis, and as you see, it causes deformities, but we will discuss it in more details in the face-to-face session. Systemic lupus erythematosus is another rheumatic disease that has arthritis in its clinical picture, and you can diagnose it when you find a female adolescent that has a multi-system disease, that has this rash. This will help you make the diagnosis. And you can confirm it by the presence of a positive anti-nuclear antibody test, a high anti-DNA titer, and consumption of complement 3 and 4. Infections are the second big group of arthritis, and these might be bacterial, viral, fungal, or spirochetal. Bacterial or septic arthritis is caused by staphylococci, group A streptococci, strep pneumoniae, and Haemophilus influenza had been recognized as the most common cause below 2 years of age, but it's no more like this, and we will see why in the face-to-face session. Kingella kingi is seen below 5 years of age. In sickle cell anemia, they have Salmonella as a cause of arthritis, and in neonates, group B streptococci, staphylococci, and gram-negative bacilli. Bacterial arthritis is more commonly seen below the age of 3, but it can occur at any age. It's more in males. It has a tendency to take the hips or knees, and it is usually monoarticular in more than 93% of cases. The arthritis is acute and can be diagnosed by laboratory investigations such as the presence of polymorphonuclear leukocytosis. A positive blood culture also can help. You have to take 2 blood cultures. And the effusion in the joint can be detected by ultrasound and more sensitively by magnetic resonance imaging. Aspiration of the joint fluid can help make the diagnosis of septic arthritis if you find polymorphonuclear cells, and you can do culture and sensitivity from the joint fluid aspirate. Septic arthritis is treated with antibiotics, and the combination of cefotaxime and nafcillin is recommended. We can also give the patient clindamycin or vancomycin, especially if it is a methicillin-resistant Staph aureus that is community acquired. The duration is controversial and may take up to 6 weeks treatment or more, and parenteral administration of antibiotics is recommended. Of course, any pus should be drained. Brucellosis is a cause of arthritis in patients living in the countryside, and there is a history of animal or food exposure. This will help you make the diagnosis of Brucellosis arthritis. The presence of fever that is either intermittent or undulant, seen in 90% of patients, together with the presence of hepatosplenomegaly, can aid in the diagnosis. Brucellosis might take an acute, subacute, or chronic course. If it occurs below the age of 15 years, then it most commonly takes the hip and knee. If it's after that age, then it has a preference for involving the sacroiliac joint or the spine. The diagnosis is made by doing blood cultures. Doing serum agglutination test, it will be high. The treatment is for 45 days with trimethoprim and sulfamethoxazole combination. If the patient is sensitive to sulfa, then you can give rifampin, aminoglycosides, or tetracyclines. Fungal infections characteristically affect immunocompromised children, whether they have primary immunodeficiency with T-cell defects or secondary immunodeficiencies. The presence of hyphae and spores in culture from the synovial fluid will help confirm the diagnosis. Viral infections are common causes of arthritis, and they occur either by direct invasion of the joint with the virus or as a post-infectious arthritis, as we will see in the group of infection-related arthritis. Examples of the viruses are rubella, mumps, varicella, and HIV. The arthritis is migratory and may intermingle with that of rheumatic fever, but here in viral arthritis, the presence of the high fever with the flu-like manifestations or the presence of the rash or the swelling of mumps will help differentiate between both conditions. Mycobacteria as a cause of arthritis have an insidious onset and a slow course, like tuberculosis, of course. And the diagnosis can be suspected if the patient have manifestations of TB toxemia, have evidence of pulmonary TB or positive family history of tuberculosis. You can do a tuberculin test, and a high ESR is highly suggestive. The presence of lymphocytosis and monocytosis in the peripheral blood, the presence of mononuclear cells in the synovial fluid, the use of the blood test, which is the quantiferon gold test, will also confirm the diagnosis. The third big group of arthritis are the infection-related, and these are reactive or post-infectious arthritis. The reactive arthritis, the joint becomes inflamed in response to an infectious agent that is currently present, or has been present in some other part of the body, not in the joint. Usually this part is either the gastrointestinal tract or the genitourinary tract. By definition, the viable infectious agents are not recoverable from the joint space. And this results from immunological cross-reactivity between articular structures and infectious agents, what we call molecular mimicry. Clinically reactive arthritis, there will be history of a distant infection in the GIT or the genitourinary tract. There will be history of travel to an endemic area or exposure to sick animals. There are other family members who have diarrhea, and whenever you find affection of the large joints together with diarrhea, you have to think of reactive arthritis. This is treated by giving non-steroidal anti-inflammatory drugs for the joint, but you have also to treat the distant infection according to the organism. The post-infectious arthritis or the transient arthritis has been termed before toxic synovitis because they once thought that there are toxins that go to the joint and cause the inflammation. In fact, it is the formation of immune complexes that contain non-viable components of the infectious agent that go to the joint and cause the inflammation. This usually follows upper respiratory tract infection, and it has a preference for the age group from 3 to 10 years. It mostly takes the hip joint. The patient has a picture that is milder than that seen in septic arthritis. The ESR is normal or slightly elevated. The white blood cell count is normal, or there is mild leukocytosis. There is no positive blood culture, of course, it is negative. And the patient is not that toxic and not in agony as the patient with septic arthritis. This acute arthritis is also treated with non-steroidal anti-inflammatory drugs because there is no current infection at the time the arthritis appears. Joint pain and swelling can be seen after trauma, and usually in trauma the affection is monoarticular and occurs near the trauma site. This trauma might also be a cause of septic arthritis when a spike, like a child playing in the garden, the spike pierces and falls on his knees. A spike might pierce the knee and cause septic arthritis. But trauma per se causes joint pain and swelling. In hemophilia, hemoarthrosis can be seen. In leukemia also, either hemoarthrosis from the thrombocytopenia or the pain that occurs as a result of bone marrow expansion and the pain in the bones. This might occur near the joint and give a picture as if there is arthritis. You can suspect it when you find neutropenia with lymphocytosis or thrombocytopenia. All these raise the possibility of leukemia, especially also if the pain occurs in the night time. Pancreatitis is another cause of pain in the joint. I'm waiting for your questions in the next face-to-face session, so prepare your questions. And I wonder if you are ready now to answer this question. Read it carefully and we will discuss your answers in the face-to-face session.